So, good morning? No, good afternoon. Let's start with an appropriate time feeling. So my name is Joost Wijner. I'm a professor in epidemiology from the Antwerp University. In the Antwerp University, we have a master in epidemiology since a couple of years now, and I'm program director of that master program. Today, we are going to talk about concepts that are used in epidemiology. So the title of the course is Concepts of Epidemiology. And I will try to cover the topics that I want to share with you in 5 sessions. And the first session today will be a session where we talk a little bit about the history of epidemiology, which is a very old history. I would say that epidemiology is as old as medicine. Then I want to give you some definitions of epidemiology. If you ask 5 epidemiologists what the definition of epidemiology is, you would have at least 6 or 7 definitions. So this is one of the big challenges, is understanding what epidemiology is about. Then I want to explain that in epidemiology, and when I talk about epidemiology, most of the time it would be epidemiologic research. So you could also say applied epidemiology. We will discuss most of the time epidemiological research. So when I refer to epidemiology, it would be research. And then we will discuss what is the object of epidemiological research. And then at the end of this session, I will introduce you to the measures of frequency that we use in epidemiology. One of my problems is that I never achieve in covering the whole thing in one session, and the whole thing in 5 sessions. So we will see how far we will go today. So maybe important is to know that what I will tell you is not something that I invented myself. So I have been inspired by a lot of epidemiologists. I have been a student of Kenneth Rothman. This was one of my first professors in epidemiology. And then I studied epidemiology with Olli Miettinen, who is, to my understanding, one of the most important founding fathers of modern epidemiology. And then, so if you want to buy a book, it depends on what is the purpose of buying the book. If the purpose of buying the book is to show your friends how smart you are, then you should definitely buy the books of Olli Miettinen. So you put them somewhere, and if your friend or one of your friends is asking, what are you doing lately? You just tell them that you are studying epidemiology, and then they will ask, what is epidemiology? Show them the book, open the book, and they will say they will be amazed how smart you are. If you want to buy a book that would give you a good basic introduction to epidemiology with not too much effort, I would advise the second book, because the first book on the list is not available anymore. So it would be Epidemiology, an Introduction by Kenneth Rothman. It's a very straightforward book, easily to read. And basically the most important things are there. What is very important, though, in the book of Kenneth Rothman, is that the book is an introduction to a part of epidemiology, and that part that is dedicated to causal research. But nevertheless, it's a very good book. Then if you want to buy a modern book, inspired by the work of Olli Miettinen, to a great extent inspired by the work of Olli Miettinen, then I could advise you to buy the book Clinical Epidemiology by Dick Grobé and Arno Hoes, 2 epidemiologists from Utrecht University, from the Netherlands. And this is, I think, a very interesting book, because they don't only discuss causal research, but they also discuss prediction research, which is, to my understanding, one of the very big challenges of modern epidemiology. So Dick Grobé, Clinical Epidemiology. It's a very interesting book, even if the title is suggesting that it is only about clinical epidemiology, also for people involved in population epidemiology. in public health epidemiology, this would be a very good book, introducing you not only into causal research, but also into prediction research. Now, very important, something that we should discuss always at the beginning of a course, is how the students will be evaluated. So my suggestion is we will have an oral exam, open book, so you can bring whatever you want. You can bring a friend if you want. The exam will be, there will be two parts in the exam. One part, and that's the start of the exam, will be based on a topic of your choice. Yeah, so you are entitled to choose a topic that we discussed about epidemiology. We could also discuss some composer of the 18th century, but I'm not paid for that. So it should be on epidemiology. You prepare that topic, so that might be a part of diagnostic research. For example, you might want to discuss the use of Bayes' theorem in diagnostic research. We will discuss that. And throughout that discussion, I will also find out to what extent you know something about the other topics in epidemiology. So I will make comparisons, and once in a time, I will ask you questions about something else. So the discussed topics, so my expectation is that you study the discussed topics, the topics that we discussed in class. You prepare one topic, and then we will start the oral exam with that one topic. So in order to make you feel comfortable, that at least you know something about that prepared topic. Yeah. So that would be on the evaluation. And then we can start discussing a little bit the history of epidemiology. A lot of textbooks on epidemiology will tell you that epidemiology started to become important in the 19th century, and they will refer to the work of John Snow. We will also discuss John Snow, but I think it's very important to realize that people interested in medicine and in medical science have almost always been applying epidemiology, even without referring to what they were doing to that as being epidemiology. And one of the old examples, of the ancient examples, would be Hippocrates of Kos, who lived before Christ, several centuries before Christ, and who wrote a book, the Corpus Hippocraticum, on airs, waters, and places, where he suggested that the occurrence of illness could be related to the environment. And this is one of the typical topics, objects of epidemiological research, is to find out to what extent the occurrence of a disease can be related to the environment. So then, maybe for people interested in statistics, a very important person was Domitius Ulpianus, who lived in the 2nd century after Christ, and who developed a method for calculating life expectancy. So he constructed the first life table, and the tables that he developed were used in Tuscany up to 1814, when calculating life expectancy for insurance purposes. So this could be also already an ancient epidemiologist. So they were not referring to themselves as being epidemiologists, but today we would say this was already an epidemiologist. Not only in this part of Europe, this part of the world, we can refer to very old traces of epidemiological research. This person is also a very well-known, or should be a very well-known person. Avicenna, Ibn Sina is known with different names. So it's Abu Ali al-Hussein Ibn Abdullah Ibn Sina, who lived in what for this part of Europe was the Dark Ages, but they were not in the Dark Ages. They were brilliant in that period. He emphasized that it was very important to study the causes of diseases. So this is something you should study. You should not accept that for granted that people get diseases, but you should study the causes, and it's important to know about the causes of diseases. He also conducted already clinical trials to find out to what extent a therapeutical intervention would be beneficial. He described the use of quarantine processes, and he also wrote on diagnosis based on symptoms and how to do that. And this is what is very important, I would say, for clinical epidemiologists, is understanding, and of course for medical doctors, understanding how the diagnostic process functions and how people can improve diagnostic processes. John Ground is an important person, so that's not very ancient anymore. So now we are talking already in the 17th century in this part of the world, in the United Kingdom. John Ground was active on the bills of mortality. And he was interested in the quality of the bills of mortality. And you should know that in the UK, they decided to register deaths, the occurrence of deaths. And so they did that especially in periods of plague, because they thought that they could learn from that. And so from 1538 onwards, they documented every death, and they published these deaths, they published the statistics in the mortality statistics referred to as the bills of mortality. And since 1592, they decided to do that on a continuous basis and not only when there was a plague. So it's a very important source of information. They included the causes of death from 1603 onwards. So from that moment, they had something that was very important for conducting research that now would be referred to as epidemiological research. And John Ground was interested, was working on these bills of mortality, and he wrote an essay upon the bills of mortality, where he produced in-depth analysis of the bills of mortality with an emphasis on potential sources of errors and bias leading to difficulties in interpreting the findings. And he was also able to demonstrate irregularities in mortality series that might be explained by epidemics of infectious diseases such as the plague. Also, John Ground was interested in life table analysis, and he conducted a life table analysis on 100 neonates, combining the information of the neonates with the bills of mortality. And you will see that the bills of mortality will show up from time to time in this historical evocation of epidemiology. Not only in the UK. If you read the textbooks on epidemiology, quite often they are published by Anglo-Saxon authors. Yeah? And they have a very particular look at history. They predominantly look at Anglo-Saxon researchers. So from this part of Europe, the Dutch-speaking part, it's interesting to know that also in this part of the world there were people interested in conducting research that nowadays would be referred to as epidemiological research. And one of the examples is Christian Huygens, who's well known, not as an epidemiologist, but who improved the method for the estimation of life expectancy based on the tables, the live tables that John Graunt had already produced. So he improved the estimations that were made by John Graunt. Another person that, to my understanding, is a very important one is Daniel Bernoulli. I don't know to what extent you know what his main work was for epidemiology or for biostatistics. You have the answer? So he developed a logistic regression. Yeah. So when I didn't went into the details of my background. So I'm a medical doctor. So when I started to become an epidemiologist, I was exposed to things like linear regressions and logistic regressions. And for a medical doctor who stopped being involved in mathematics for years, it's not very straightforward. You have to realize that. If later in your career you will work with medical doctors, you have to realize that for them, the mathematics is really a problem because you lose that. It's not like riding a bike, riding a bicycle. That's something you will always be able to do that. Mathematics, it's different. So when I was first exposed to logistic regression, I thought this was higher maths. Now I understand that this is not very difficult. Yeah? So Bernoulli in the 18th century developed a logistic regression for the modeling of the prevalence of smallpox. Yeah, so it seems to me rather straightforward in coming up with this idea of using a logistic regression. Another thing, of course, is the estimation of the parameters of the model. That's another story. But coming up with the idea of developing a logistic regression is not that very complex. So Daniel Bernoulli, very important. Then we continue with a person that you will find in the Anglo-Saxon books on epidemiology against Sydenham, Thomas Sydenham, who wrote a book on epidemics. Now you see the word already emerging, on epidemics. And what was important in that book on epidemics is that Sydenham emphasized that it was very important if you want to conduct research, and this is also nowadays very important to always stress that, is that your observations should be accurate and that you should have an appropriate registration of all these accurate observations. So as a medical doctor, I'm entitled to say, you will not be entitled to say that because you are not medical doctors, but as a medical doctor, I'm entitled to say that the quality of the data that you will find in the records of patients most of the time is very poor. The quality is very poor. And that is because of the fact that the information that you will find is not collected with the purpose of doing scientific research, but with the purpose of following up the patient. So it's very important to realize. So if you want to do good research, you need very precise data. So one of the things we want to explain is variance. A lot of variance in medical research is the result of imprecise data. So accurate observations, very important, and then also collect and register the information. And this was also the interest of Bernardino Ramazzini from Italy, lived in the 17th, 18th century, and this person could be presented as being the founding father of occupational medicine and even occupational epidemiology, if you want. He wrote a book, De Morbis Artificum Diatriba, a discourse on the illnesses in workers, where he described more than 50 occupations and illnesses that occur in the workers in these occupations. So it dealt with miners, pottery workers, midwives, wine farmers, singers, fishermen, farmers, whatever you want. So he described very accurately what the typical health conditions, diseases were that occurred, especially in these occupations. So you will not find a lot on Bernardino Ramazzini, because he was an Italian. So if you know that if you want to be successful, you have to be on the right place at the right time. So Italy in those days was, or for the history of epidemiology, was not the right place. So this is in contrast to Percival Pott, who is very well known, who also did work that could be considered as occupational epidemiology, because he described the occurrence of scrotal cancer in chimney sweepers. He also, before that, wrote on the risks of tobacco smoking. So when we talk about cancer risk and tobacco smoking, we most of the time would refer to the work of Doll and Hill, last century. But already in the 17th century, people were aware that smoking was a hazard, and that one of the effects of smoking was the occurrence, especially pipe smoking, was the occurrence of lip cancer as a consequence of the exposure to carcinogens. Yeah, so very important person. And then a story that is nice to look into with more detail. It's the work by James Lind, who was a naval surgeon in the 18th century, and who is important because there is a nice documentation on the work that he has been doing, and we could discuss a little bit his work because he was conducting a trial, an intervention trial. So this is one of the first nice sources for finding out how in those days people were conducting trials, and it's different compared to what we do now. There are similarities, but there is a lot of difference. So the trial was on the treatise of scurvy. So maybe you know what scurvy is. Nowadays, this is a very rare condition. But in the period of James Lind, when he was a naval surgeon, it was a very common condition in people that went at sea for longer journeys. And we now know that the explanation of scurvy is a deficiency of vitamin C, leading to a lot of symptoms. So I have them there: loose teeth, bleeding gums, and hemorrhages. And if untreated, the patients would die. What is very important, also for your career, is that James Lind was not completely naive when he started his research. People knew how to treat scurvy, but nobody had conducted a proper study on that. So it was based on observations. And one of the observations was that there was, at a certain moment, a story of a crew of people that were on a long journey at sea, and they had an accident, and then the crew was on an island, and they were received with a lot of respect, because you should imagine that those people living on that island, they have never seen people coming from the sea with these very special clothes, so they must have been at least something very close to a god. So they were, so people were very welcoming these victims of that tragedy at sea, and then they received food, they were treated well, and one of the specialties of that island was that they were eating a lot of oranges, lemons, and things like that. And what they never observed before was that there was a spectacular improvement of the health status of those with scurvy. And as a consequence of that experiment, which was not what nowadays we would say a scientific experiment. It was almost by chance that they received these oranges. As a consequence, people knew, or people were aware of the fact that maybe using oranges would be beneficial. And the ships that went for long journeys at sea, they also brought oranges. They had oranges in order to do something about scurvy, about the occurrence of scurvy. But then you had this James Lind who said, let's now do a proper study. So this is something that you have to realize. If you want to become famous, successful, study things that everybody knows, but nobody studied. Because up front you know what the result will be, and there will nobody will contradict your findings. So this is what James Lind did. Now, interesting is to have a look at the publication. So this is a facsimile reproduction of the publication by James Lind. So it's just a part of that publication. So let's go through that. So he writes, the following are the experiments. So this is what nowadays we would have in the chapter Material and Methods. So there's no title, there's just the following are the experiments. On the 20th of May 1747, I took 12 patients in the scurvy on board the Salisbury at sea. Their cases were as similar as I could, and now you have to look at the last word, have. That last word is located at a place that you would not expect that there would be a word. It's the first word of the next page. It's because people were not able to read. Not all people were able to read. And they were reading these publications loud, so that's the point for turning a page. So you know that the next word, the first word on the next page would be have. So their cases were as similar as I could have, and then you see have again, them. So this is very important. James Lind was aware that in order to do proper research, intervention research, you should avoid confounding by indication. This is epidemiology. What is confounding by indication? That you would treat people with a specific stage of disease, and then you would have a control group that is not treated, but they don't have the same stage of disease. So he says, let's now try to find a group of scurvy patients that all have the same stage of disease, and he describes it. So they all in general had putrid gums, the spots and lassitude with weakness of their knees. They lay together in one. So so the symptoms are more or less the same. Now, so I would say now he is describing the control. This is not what currently we are discussing when we talk about a controlled trial. But here he says, they lay together in one place, being a proper apartment for the sick in the forehold. This is controlling your experiment, making sure that you are in charge, you are controlling everything. So they lay together in one place, they had one diet common to all. Let's control the circumstances under which the experiment takes place. And then he describes the diet. So this is if you want to cook like people cooked in those days, this is how to do it. So so water gruel sweetened with sugar in the morning, fresh mutton broth oftentimes for dinner, at other times puddings, boiled biscuits with sugar, and so forth. And then for supper, resins, rice, currants, fago and wine, or the like. So now when we talk about a control trial, we think immediately about an intervention group and a control group. A scientist, someone who is in physics, when he's conducting an experiment, the control is on the circumstances, not on a control group. So this is explaining that he's controlling his experiment. Now, after that paragraph on controlling, he explains what the different treatment options were. 2 of these were ordered each a quart of cider a day. 2 others, so 12 patients, and then 6 groups of 2 patients. So you as statisticians, you have immediately the feeling this is small sample size. But he was not very worried about that. So 2 others took 25 guts of elixir vitriol 3 times a day upon an empty stomach, using a gargle strongly acidylated with it for their mouths. 2 others took 2 spoonfuls of vinegar 3 times a day upon an empty stomach, having their gruels and their other food well acidylated with it, also the gargle for their mouth. This is a little bit strange now. 2 of the worst patients, so he starts saying that they are all the same. Nevertheless, there were 2 worst patients. So this is a contradiction. 2 of the worst patients with attendance in the hemorrhage, a symptom none of the rest had, were put under a course of seawater. Of this they drank half a pint every day, and sometimes more or less as it operated by way of gentle physics. So you know that the disease had to do something with soft tissue, so maybe physics would be, gentle physics would be a treatment. And then 2 others had each 2 oranges and 1 lemon given them every day. These they eat with greediness at different times upon an empty stomach. They continued but 6 days under this course, having consumed the quantity that could be spared. And then the last 2, the 2 remaining patients, took the beignets of a nutmeg 3 times a day, of an electuary recommended by an hospital surgeon, and so forth and so forth. Yeah, so 6 treatment regimens. I would say that maybe at first sight you say, why these different treatments? But there is logic in it. So if lemons and oranges would be good, maybe the juice of other fruit would be good, cider. If lemons and oranges would be beneficial, maybe it's the acid that is responsible for that, so vinegar. So it does make sense to do. Then you have these 2 patients that have problems with the hemorrhages, with the hamstrings, and they were put under a course of gentle physic. Then you have the oranges, and then you have a group that is treated with something that a hospital surgeon would advise to do with these patients. So a nice description of the treatment, and then the results section. So no heading. Immediately a new paragraph on the results. The consequence was that the most sudden and visible good effects were perceived from the use of oranges and lemons. He knew that up front, of course, but now there was a nice experiment. That one of those who had taken them, being at the end of 6 days fit for duty. So this is the hospital surgeon who does his work. He has to make sure that the crew is fit for duty. So he was not quite cured. The spots were not indeed at that time quite off his body, nor his gums sound, but without any other medicine than a gargarism of elixir vitriol, he became quite healthy before we came into Plymouth, which was on the 16th of June. So that was the big success. Then the other patient treated with the oranges and the lemons was almost a big success. I would say this was the smarter patient. So the first one was maybe the dumber patient. He was fit for duty. And then you have the smarter patient who says, well, I feel better, but I'm not fit for duty. So the other was the best recovered of any in his condition, and being now deemed pretty well, not completely cured, but pretty well, was appointed nurse to the rest of the sick. So he had a special. So this is also occupational medicine. So you have to prescribe a different type of work for the ones that are not able to do their proper job. And then maybe also important, next to the oranges, I thought the cider had the best effect. So, and it's only later that they were aware of the fact that it is vitamin C, which is a very important component in fruit and vegetables. So this is the story of James Lind. A very successful story. The stories are not always very successful, at least not in the lifetime of the researcher. You should also be aware of that. So I gave you already a clue for being successful. Study the things that people already know but never studied. Be careful with what you study, because the example of Inga Semmelweis is a nice example of showing that it might also go wrong, even if you do your job properly. So what was the story of Semmelweis? Semmelweis was a gynecologist, obstetrician, and he was a student he was working as an obstetrician in the University Hospital of Vienna, and he was interested in a problem that occurred in the University Hospital, namely the occurrence of epidemics of puerperal fever, which is a very serious condition in women that delivered a child. And nowadays we know that it is due to a bacterial invasion, and it is a very lethal condition. And Semmelweis was interested in explaining the epidemics. And he found out that the occurrence of the epidemics was related to the activities of the medical students. And whenever the medical students were doing internships in the Department of Obstetrics, there might be an epidemic. And then he went further into detail, and it turned out that it was explained, or that the epidemics, the probability of an epidemic was the highest when the students, before going into the internship of obstetrics, before going into the delivery rooms, they were doing pathology, and they helped the pathologist with searching the dead bodies, and then without washing their hands they would do a delivery, and that would be the source of contamination. So Semmelweis advocated that they should wash their hands, which is a very simple way of dealing with that problem. And this is quite often people refer to the success of epidemiology with these type of examples, because quite often, without really knowing what the mechanical or what the biochemical or the biological explanation of the occurrence was, they were able to do something in order to reduce the probability of getting the disease. So Semmelweis advocated that it would be important to introduce hand hygiene, and you can see here what the effect was, and it's also very tragic to see that the risk was higher in the medical doctors than in the midwives to have this problem, and probably it was related with the fact that these medical doctors would come from different departments and then would introduce the pathogens in the delivering women. So the sad thing is that that Semmelweis presented his results publicly, and as a consequence, he was disliked because he had put the University Hospital of Vienna he embarrassed the University Hospital of Vienna, and so there are different stories of the rest of the life of Semmelweis. One of the stories is that he, at a certain moment, in order to prove that he was right, injected himself with the blood of women that died from puerperal fever, and then and so forth. So it's a tragic story. Now, and this is, of course, something that the people doing e-learning will never know unless they would see me on the occasion of an oral exam, is that a very important person for epidemiology and quite unknown person for as an epidemiologist is William Farr. And I think when I started to become an epidemiologist, my former boss, told me that I had the looks to become an epidemiologist. And when I saw the image of William Farr, I understood what he meant. So either it's the beard or the body mass index that you need. So William Farr was a medical doctor and also a statistician, and that's the combination that you need to become an epidemiologist, which is not completely true, of course, but it helps. He was referring to what he was doing not as I'm an epidemiologist, but he was conducting hygology. So that was his idea about what he was doing. He was in hygology. William Farr was, I would say, to a large extent also the man behind John Snow. John Snow is the best known example for old epidemiology, if you want. But I would then say that maybe William Farr would be the better example. William Farr worked on the bills of mortality again. So this is another story of the bills of mortality. He was working there as a statistician. William Farr was also a member of the Royal Statistical Society. There was, in those days, not an epidemiological society. There was a Royal Statistical Society. So he's a very important person, inspiring, working on routine data, something that nowadays becomes also very popular. People have this idea that as we collect a lot of data, we should do something with these data, big data. I would be very cautious with this type of data, but he was working on the routinely collected mortality data. And one of the reasons why people forget about William Farr is that you should realize that in those days, there were two theories about the occurrence and the risk or the genesis of cholera. So there was the miasma theory and there was the germ theory. And William Farr was a disciple of the miasma theory. And miasma, it's like malaria. Yeah? So it's bad air. Malaria is bad air. Miasma is referring, asthma, you know what asthma is. It's a condition, it's a health condition related to the airways. So miasma, you could translate that as bad air. So they were convinced that people suffered from cholera as a consequence of having been exposed to bad air. And in London, the bad air, the source of the bad air would be the River Thames. Because all the sewage of London went into the River Thames. And in order to demonstrate or to find some evidence for that theory, William Farr, based on the bills of mortality, produced a table where the risk of dying from cholera was, it's bills of mortality, so it's not the risk of getting cholera, but the risk of dying from cholera would be presented as a function of the elevation of the district in London above the River Thames. And so you can see in that table that the higher the district was located above the River Thames, with one exception, and then there was an explanation for that exception, but the higher the location of the district above the River Thames, the lower the risk of cholera mortality. Indicating that this is evidence for that miasma theory. Okay, so that's the work. So he is the one who was able to work with the data. We would now, a lot of people would now say this is epidemiology because of the fact that William Farr was not looking at the absolute number of deaths, but he was looking at the number of deaths per 10,000 inhabitants. So this would now be a measure of disease frequency, something that epidemiologists study, disease frequency. Now, there was another person, John Snow, who was not working somewhere in secret in an institution making use of or registering the mortality data. No, John Snow was a famous guy. He was an anesthesiologist, and he was the doctor of the Queen. Because whenever the Queen delivered, he was there to give her a painless delivery. So that he was well known. He was a famous medical doctor. Also interested in cholera and trying to explain why people get cholera. And he was a disciple of the germ theory, meaning that people would get cholera by swallowing something that contains germs, and that would be the explanation. I will show you what the idea of these germs, so the image people had from these germs, what it was. So what was the problem? In 1854 is that in one limited geographical area, the Soho district in London, and for those of you that have visited London, it's really in the center of London. There was, they had, within a period of 10 days, 500 deaths due to cholera, which is quite impressive. And John Snow, in order to, so he had an idea about why people would get cholera, and he wanted to show what happened, and he plotted the deaths, all the cholera deaths, on a map of London. So this is the map of John Snow. You can find that on the internet. And you can see that there seems to be a clustering of cholera deaths around one street. And in that street is the Broad Street in the Soho district, something that you will not be able to read. Here there is a pump. So I have another image of the district where you can see the pump. So in the Broad Street there was a pump, and the deaths were clustering around that pump. So this is an analysis on absolute data, absolute numbers, clustering of cases around the pump in the Broad Street. The water, so underneath the pump there was a reservoir, and the water was supplied by the Southwark and Vauxhall Company. So there were different water companies in those days for London supplying water for the different pumps. And that was for John Snow an argument for the germ theory, and then he advised the mayor of London to remove the handle from the pump in order to stop the epidemic. Now, what John Snow also did is he talked with William Farr, and he asked William Farr to do a sort-like analysis as what he has been doing for the height of the districts. So if you are able to do that for the districts as a function of the height above the River Thames, maybe, William Farr, you can also do that for the sources or for the providers of the water in the different districts. And this is a table that is closely linked to John Snow, but that table has been produced by William Farr, showing that indeed the risk of dying from cholera was the highest in the district supplied by the Saltwerk and Vauxhall Company, and the lowest in the district supplied by the other big water company in those days, the Lambeth Company. And where in the districts where there were pumps from both companies, the mortality would be intermediate. So this was an argument, not based on absolute numbers, like in the maps, but on frequencies expressed in deaths per 1,000 inhabitants, in this case. And this is why a lot of people would say this is epidemiology, because this is now a person studying disease frequency as a function of a determinant, the water supply. So that would be epidemiology. The measure of frequency would be an incidence. It's the incidence of deaths, of cholera deaths in that population. Now, if we would talk because epidemiologists, they would then compare measures of frequency. How would you compare these measures of frequency? What would you do? Just suppose that you would have to argue with the mayor to remove the handle of the pump, and you would say, well, the risk is higher in the districts where the water is supplied by the Vauxhall and the Saltwerk and Vauxhall Company. And the mayor would ask, what do you mean higher? Can you quantify higher? How would you do that? If you look at that table.
5,000 number.
Yes.
That is 194 for the first one, and the last one 400 criteria. In both.
So you would look at the cholera mortality per 1,000, the last column. Yes? And then you would say that the difference would be per 1,000. So that would be, here would be 4.1 deaths per 1,000. That's how you would do that? Approximately, yes, because you are a statistician. Yes. So 4.1 approximately, because you are never sure. Everybody agrees on that? Someone, another approach of saying something about the difference in risk? Because what you explained, if I understood you well, is the difference. But if we talk about the difference, quite often we don't express the difference. So what would be an alternative way of presenting that association? So what would you do? They will not hear you. It's very straightforward. And I would say more intuitive. It's one of the first times that someone gave me that reply. 4.1 per 1,000. If you compare the ones with the Southwark and Vauxhall Company, the districts with the districts only Lambert Company. It's only Wednesday. So it's not a Friday, it's not a Monday, you should now be it's very straightforward.
The reason and the effect.
No, but you have to talk to a mayor. Yeah? It's not a scientist. Yeah? So you have to say something about the risk of dying in a very simple way. I would say 4.1 per 1,000 is not a simple way. It's correct what you state, but it's not the simplest way of talking about a comparison of risks. What would you say? What would you say?
I would do it with an alteration, maybe.
Oh! Oh! And that would be simple.
No.
That's not a problem. That's not a problem. It's a problem in the mind of some. But she would prefer a ratio.
Yeah,
A ratio. An odds ratio would not be the most appropriate one, maybe. Though I would say that maybe you should go for an odds ratio, but you would go for a ratio, not for a difference. So we would talk, and this is one of the problems that you should realize. I'm only entitled to say something about medical doctors, but we are very sloppy. We would say we will talk about the difference, and we would talk about the ratio. So you say the difference is that there is a 5-fold increased risk.
To mayor, I would try once again. For the first case, I mean to the place, if the water, if the mayor approves the water supply from that first source, the people are more dying for cholera.
Yes.
So if you add another source with the first one even, the death number will be reduced.
If you would change the source, yeah, but now you are dealing with something that is very complex. Yeah? Because you don't know that. This is interpretation. Yeah? So this is very important because in causal research, in epidemiological causal research, causality is an interpretation of your findings. You will not prove causality. So here, the interpretation might be that if those exposed to that water would not have been exposed to the water, but to the Lambert Company water, they would have the same mortality as those drinking the Lambert Company water. But you don't know that, because they have been exposed to the... So this is this counterfactual reasoning that is very important. And you have to realize that if you can't live with that, you should not do epidemiology. You will not be able to prove it, but we have findings. Now we interpret our findings. And your interpretation would be that if we would change the water into Lambert Company water, there would be a reduction. Yes, but that's your interpretation. So I would say now you have a causal interpretation of the findings. Now you would like to find some proof by doing an intervention. And then doing the intervention would give you the same problem, because you have to go back to that counterfactual reasoning in order. Yeah, so that's, yeah. But I would say that for the mayor, probably saying that the risk is 5-fold would be good. Nevertheless, if the risk would be almost nothing, a 5-fold is also almost nothing. So it is good to have both this 5-fold risk and this 4.1 per 1,000. But in epidemiology, we would go for odds ratios. Yeah. And there are good reasons for going for odds ratios. I would say that in modern epidemiology, we should go a step beyond that. Yeah. Okay, so fivefold risk. So we have a measure of frequency, a number of deaths per 1,000 inhabitants, and then we would have a measure of effect of fivefold risk, or a 4.1 per 1,000 inhabitants. But it takes a lot of effort to pronounce that, so fivefold risk is easier. Now, I think very important in the work of John Snow is that he didn't stop there. So he asked himself questions in order to be enlightened about what was going on. And one of the problems was that now the analysis was based on a district level, not on the individual level. And this is a problem. If you want to do causal research, you would like to know who, what person, what individual is exposed and what person has the disease, the outcome, not on a group of persons. So here they were aware that it is not because you are living in a district where the source, where the pump would be supplied by the Saltwerk and Vauxhall company that you would drink the water. So he tried to investigate that. And there were some stories. For instance, there was one district where the people were, where the pumps were supplied by the Saltwerk and Vauxhall company, and cholera mortality was low. And the explanation was that in that district there was a brewery, and the people, it's not because they drank beer rather than water, but the people working in the brewery took the water from the brewery, not from the pumps. And in the brewery they were using the Lambert Company water. So that was, so he said there's a problem. And then there was another story of an old woman that lived in a district where the water supply was Lambert Company, and she went to a pump of the Saltwerk and Vauxhall company because she preferred the taste of that water. She got cholera and died. So John Snow was smart enough, and this was probably also inspired by the work of John Ground. Be careful with the analysis of these data, because they are aggregated data, and you should try to come as closely as possible to the individual exposure. And he asked William Farr to redo the analysis. And this is an analysis not based on district level, but on household level. So now you are already much closer to the individual exposure. And this is the result. The problem in epidemiology that occurred in the prior analysis would be referred to as misclassification of exposure. So those that are classified as being exposed to the Saltwerk and Vauxhall company were not all exposed to that water, but some. So you have to adjust for misclassification of exposure, and this is an attempt to do that. So by going at the household level, not at really the individual level, but at household level, and what do you see now? Now we can discuss your measure of association again. If you look at your measure of association, what happened? So we tried to improve with respect to misclassification. And we have the feeling that we improved. What would be your expectation if you look at the measure of association? So this is epidemiological thinking. What would happen if? So if in an analysis those exposed are not all exposed, and those unexposed are not all unexposed, and there is an effect, if you would improve that misclassification error, what would happen to the measure of association? I would say the contrast would increase. So the expectation would be that the measure of association would go up. Now, if you look at your measure of association, it was 4.1, all more or less 4.1 per 1,000. Now it is? No, it is 3.7. So it decreased. So I would feel uncomfortable about my measure of association. On the contrast, if you look at the ratio, it increased. So this is probably one of the reasons why we feel comfortable about these associations made by ratios, because they are stable. More or less stable, because it increased up to 8. When I show that table to young students, you are also young students, but I would say very young students, first year medical training, coming from high school, they are still very critical. So we have this intention to form our students at universities in such a way that they would become critical. My impression is that at our universities we form the students and make them less critical. So a youngster of 17, 18 years of age is very critical. So I showed that table to first year medicine students, so both tables, and there was one student that had a question about the tables. So I show them, I toggle between the first with misclassification. So you understand the misclassification. Now we are going to remove or reduce the misclassification. You have to think up front, what is your expectation? What will happen with the 5 per thousand? What should happen with the 0.9 per thousand? If I would remove the misclassification, reduce the misclassification, what would happen with the 5? So I remove the lesser risk people. If I remove those at lower risk from that group of people, from the 167,000 inhabitants, what is your expectation that would happen with the 5 per thousand risk? It would increase. That's your expectation. On the contrary, what would happen if I would remove the ones with the higher risk from the Lambert Company population, from the 19,000? It should decrease. And the consequence would be a bigger contrast. So, keeping that in mind, what do you see? It decreases both. The population changes. It's not the, you have to, okay, the population changes, but it's the same data. But different allocation, because now we are looking at the individual. So what might be the explanation? Well, probably if you add the numbers, the total here is smaller. So there will be people where you don't have the information on what water they are drinking. So the populations are different. So what might be an explanation? So one student asked, how come? How come? That where I would expect the 5.0 to go up, it goes down. This is, generally speaking, the problem of epidemiological causal research, is that it is observational research. Yeah? So you are not able to control everything. And I would say that in causal research, in genuine causal research, you will never be able to control. It's only an illusion. Some people really think that they can, but I disagree upon that. You will only be able to control by analysis, not by design. Okay, so you are not able. So what might be the explanation? It's different populations. They might also be different with respect to other characteristics that are relevant for dying for cholera. And what would be the most obvious characteristic that you think of? So what would be a very important risk characteristic for dying for cholera? So it's a study on cholera deaths, not on cholera incidents. Not getting cholera, but dying from cholera. What would be, apart from being exposed to cholera, an important characteristic that might explain why people die from cholera? It's very straightforward. Nobody is seeing what you're doing. For the ones at home, that would be something with money? You would say income. No income. Yes, that might be a problem. So there might be a difference of socio-economic status. What might be another? In 1854? It might be. It might be. But a characteristic that you always should, I would say, first think of. So, what is a very important risk factor for dying of any cause? This is about infections. But apart from that, age. Yeah? Yes, age. Yeah? So you should realize, if you have two populations, one characteristic that might explain a lot is age differences. The age disease risk association is very, very, very strong. Yeah, you will almost never find a characteristic that is so strongly related with the risk of dying than age. And the risk is U-shaped. So at a very young age, you have a high risk of dying, and then at an older age, the risk could also increase. So it might be age. So, in consequence, so John Snow indeed went to discuss with the mayor, and in consequence of what John Snow, what I said, the handle of the pump was removed on the following day. And the epidemic was stopped. Probably not because of the fact that they removed the handle, but spontaneously, as a lot of epidemics would disappear. Yeah. So what was the story behind the Salter and Vauxhall and the Lambert Company is that people were aware of the germ theory. And the people from the Lambert Company had decided before 1854 to change the location of the water collection from the River Thames to upward London. So the Southwark and Vauxhall Company took their water from the Thames in the middle of London. And all the sewage was in the Thames. And the Lambeth Company went up from London. And they had a more or a less contaminated water. And that was the explanation. And so in the Southwark and Vauxhall Company, there was more taste. So that's why the old female person preferred the taste. So we don't discuss tastes, don't we? So this is an image of the Southwark and Vauxhall source in the middle of London, and all the comments saying that this is awful water. This is what they thought of the germs. I don't know whether you know the famous Dutch painter Hieronymus Bosch, but he has been making paintings like that 200 years before that. Yeah. So it is. They were inspired by the work of old painters when they thought of the germs, I think. Again, if you look at the history, that you will find different versions of the same history. So the identification of the Vibrio cholera is dedicated to Robert Koch, but in fact already in 1954, so immediately in the same period of the story of John Snow, there was an Italian scientist, Filippo Pacini, who isolated the Vibrio cholera in 1854. So I went to London and I visited the Broad Street. This is what left from the pump. So the pump is not there anymore. So there is only a mark. Here was the pump. So I took a picture of that. And this is what you can find it's a replica of the original pump. And you can see that there is no handle. And then there is a story that the handle is kept in the pub that you can see on the corner of the street. So I also went into the pub as a tourist. Yeah. So finding out the roots of epidemiology. I can advise you the pub. It was the first time that, as an adult, I went into a pub in the UK. It's a very strange experience. The British drink beer in pints that are enormous. And I was looking, so I ordered a pint. I'm looking for the handle, and I didn't find the handle. And then when I paid, I asked the waitress, where is the handle? And she started laughing, and she said, there is no handle. But we are very happy with the story. Because a lot of epidemiologists come here to look for the handle. So it's recycled, yes. They use it for... Okay. I want to tell also the story of these two gentlemen. And one of the reasons is because I want to show you what the life expectancy of epidemiologists. We already discussed life expectancy. If you look at the life expectancy, or the birth and the day of... So if you look at the age that these two epidemiologists had when they died, I have met Richard Doll, not Bradford Hill, but it is not bad. Yeah? So if you want to become an epidemiologist, you have a good life expectancy. I will show you the life expectancy for female epidemiologists as well. So it's not bad. They became famous for their work on smoking and lung cancer. They conducted 2 studies. First, a case control study. Very straightforward, I would say a very good design. There's a lot of comment, a lot of criticism on that design, but this is not really appropriate. But themselves, they said, well, that's not the best design that we can imagine. It would be better to conduct a cohort study. So you should realize for the case control study, they used 2,000-3,000 study subjects. for the cohort study, it's several 10,000 study subjects. For the case control study, it took them a couple of years to have the results. For the cohort study, it took them decades to have the results. So if you succeed in convincing people that you would preferably do a cohort study, it would be good for your business, because they would pay you for huge studies that take decades. Yeah, so this is, I think, what happened in epidemiology. So most epidemiologists will tell you that preferably for causal research you would do a cohort study. I would say it's not true. Yeah? Preferably for your business you do a cohort study, not for science. So they conducted both. Then you have one of these rare female scientists. She's on the picture, I don't know where, but it's not very difficult because there are only 2 women, and I think this one is Jeannette Lane Clepon, unknown for a lot of people, but a very important scientist that I would now refer to as one of the important epidemiologists at the beginning of the 20th century. She applied t-tests already in 1912. So you saw that James Lind was not applying statistical tests. Jeannette Lane Clepon was applying a t-test as one of the first in medical scientific research. She applied the t-test for comparing the weights of children when or not breastfed. And she conducted, I would say, the first case control study. So when people talk about case control studies, they would refer to an example like the Dolan Hill study. But she already conducted a case control study in 1926. And that study has been used by Jerome Cornfield to explain from a rational point of view the case control study. And she conducted a case control study on the causes related to gestation, parity, and breastfeeding of breast cancer. And one of the findings was that in the 500 cases, there was a mean number of children, which is something that I find a little bit strange that you talk about a mean number of children, of 3.4. I have some difficulties in imagining a child of 0.4. Yeah? But in the controls, there was 5.3 on the average, indicating that breastfeeding, that the number of children, so parity, would be protective for breast cancer occurrence. So I'd suggest that we would have a break now. I don't know what the usual time of a break would be, so I'm just looking at you. So let's start again at 3:30.